this is Annie Shreya, host of the day, and you're listening to Little Warriors by Dr. Stalin Ramprakash. I welcome you, Doctor.
Thank you.
In this episode, we're going to talk about bone marrow transplant in thalassemia. So, many parents, when they hear about bone marrow transplant as an option, I know it is already huge and overwhelming. So, today, we're going to learn and understand how to think about it. So, doctor,
Yeah.
when parents first hear about bone marrow transplant, what is their first concern?
Okay. So because immediately they start worrying, they may even think that the child might die. So in any medical procedure, we need to think about why we are doing it and what is the benefit of it.
Right.
So in terms of thalassemia, the long-term outcomes, even though immediately it is not life-threatening, the long-term outcomes can be life-limiting and they can have a quite a long life with a lot of problems. So in one of the studies which we did in India, about 25% of the patients do not make it beyond 25 years of age. So whenever we talk about transplant, you have to use in that context. But the transplant is more and more becoming a very standard procedure nowadays. And this is an option. Instead of going for lifelong blood transfusion and taking medication lifelong, we can sort of go for a bone marrow transplant, which is like a one-off cure.
All right.
Yeah.
So, doctor, could you tell us what exactly is this bone marrow transplant?
Bone marrow transplant is a medical procedure. Many people think as soon as the word transplant comes, it is some kind of operation, surgery. It is not a surgery.
All right.
So what here we will have to do is, if the bone marrow transplant is done for situations where either the bone marrow is not working, or it is have some abnormality, or if there is some genetic defect which we have to correct it. So when we do a bone marrow transplant, in a simple terms, what we do is we actually give medicines to kill off the patient's own bone marrow, and then we give the stem cells from another donor, whoever that is, to make it work. So we drop the stem cells into the patient. That just goes like a blood transfusion, and then those cells will go and settle in the bone marrow, and then it will start making new cells. So thereby, if there is a genetic defect, because the donor doesn't have the same genetic defect, then the new cells which are coming out are going to be normal. So that is basically what a bone marrow transplant is.
Okay. So how do you exactly help parents, think clearly about this?
Okay. So see, how I explain to the parents is that so there is two options. Either most of the thalassemia patients in whom we are talking about bone marrow transplant, they will be on regular medication and then they'll be on long-term blood transfusions. Usually there is not much problem at the beginning. So first 10, 12 years will go smoothly, but the problems will start after that. So that is where then once the problem starts, it keeps increasing. So like I said in the previous podcast, the Western countries, that the patient live for much longer time than Indian patients. That is because of the average sort of treatment is not as well developed. So when we do a transplant, there is some short-term risks because it is a serious procedure. So, but you have to compare this risk against what will happen if you don't do the transplant. So, like I said earlier, about 50% of the patients do not make beyond 25 years of age. So that means we can say that at 25 years, if the patient is not that well cared of, mortality is about 50%. Whereas a transplant procedure as such, depending on who is the donor, there is a risk of even death with that bone marrow transplant. It may vary between sort of 2 to 3% to 8-9% as well, depending on the situation. So the parents should always consider the normal treatment where there is no immediate risks, but there is a lot of long-term risk, versus bone marrow transplant, whereas there is some immediate risk, but once the patient is cured, they will live like everybody else. So that is the balance which they need to strike. So which most of the families, I sort of say that how much risk do you want to take in order to have a permanent cure and have a permanently normal life.
Right.
So that is a decision they will have to make. Your doctor will try to explain it and will help you make that decision.
Okay. So could you tell us in simple words, how is this different from the other regular transfusions?
See, when you are on a regular blood transfusion, you are a lifelong patient. Whether you
Okay.
like it or not,
Hmm.
you are not like everybody else.
Okay.
Okay, even though patients can live longer, but it affects their life in many different ways.
Okay.
So, for example, they may feel as a student, they may feel that they are not like everybody else. So they feel that they are not normal. So they may not study well, and sometimes getting married becomes a problem. Even in regular management, if the iron overload is not taken care of, they may not be able to have children. And in general, if you see, most of the patients do not achieve what they would have otherwise achieved because of this illness. Okay, but when you do a bone marrow transplant and they become free of the blood transfusion, free of all the medications, then they essentially like they are like everybody else, so they can achieve the full potential. So their life will more or less become normal. So
Okay.
that is what is the difference basically. So they can sort of become, because if bone marrow transplant is done and then somebody sees that patient 5 years later, nobody would be able to tell that this patient had a bone marrow transplant. It is not like some liver transplant, then you will have a big scar in the abdomen. Here
Okay.
nothing will be there, so the patient will look like everybody else, so they will have a completely normal life.
Okay. So that sounds like a big shift.
Yes,
So I believe even the time would play a role here.
correct. So see, another problem here is that, so I have already told that there is a little bit of risk associated with the bone marrow transplant procedure. Unfortunately, that risk the patient's parents have to take when they are a child.
Okay.
Because if you do a transplant when the child is young, the outcomes are very, very good. Whereas if you do a transplant when they are much older, say after the age of 18 years, ideally, if I am the parent, I don't want to take a decision. I may say, let us wait for this child to grow till 18 years. They become an
Mhm.
adult and they can take a decision whether they want a transplant or not.
Okay.
Okay, but practically that is not possible. Okay,
Mhm.
because if you do start doing a transplant after 18 years of age, there is a big risk. The risk actually sometimes outweigh what you may gain. Okay, so ideally, the thalassemia transplant should happen at a very young age. Best age group is between 3 to 5 years. After that, better 7 years is better than 10 years, 10 years is better than 12 years, 12 years is better than 15 years. So better to do it before they become an adult. So which means essentially the parents will have to take that call.
All right. So before you recommend this, what are the important things that you evaluate?
So when we do the evaluation, basically we need to make sure that the patient is in a good shape for the bone marrow transplant. So that is why the age becomes important. So if they are not very iron overloaded, none of their organs are affected, and especially if they have a matched brother or sister, that becomes the best case scenario for the bone marrow transplant. So currently across the world, if somebody has got matched brother or sister, so when we say matched, we look at HLA typing. So like blood group, there are only 4 groups, whereas if you do a HLA typing, there are multiple things which we need to look at. And there is a good chance that, when I say good chance, about 25% chance that a brother or sister can be a full match. If they don't
Okay.
have a thalassemia, and they can be a donor, and if they donate the blood stem cells, the outcomes are very good. So across the world nowadays, if there is a fully matched brother or sister for a child with thalassemia, the first treatment of choice is bone marrow transplant. Only if the family doesn't want to go to that transplant, then we
Mhm.
should consider regular blood transfusion and iron chelation.
All right. So how do these families process the idea of the donor?
Yeah, so your doctor will explain. So if a patient comes to me, I will explain the risks of each type of transplant. So there are 3 main types of donors. One is, I've already told, brother or sister.
Mhm.
So that is the first choice. If there is, unfortunately, not, only 25% will be a match, which means 70% of each brother or sister will not be a match. So if that is the scenario, so we can look at outside, other than the family members. There are bone marrow registries where people's HLA typing is done and their data is stored. So we can do a quick search to find out whether there is somebody else outside, sometimes even out of the country, who is a 10 by 10 match, a full match. So if that is the case, we can use them as a donor if they are willing to donate. The nowadays the technology has improved so much. Now even we can do a half match transplant. So mother and father always will be a half match because half of the genes to the child came from the mother and father. So they will always be a half match. So if so we go in the order of preference. So first choice, matched brother or sister. If that is not available, then we go for a matched unrelated donor through the registries. If that is also not available, we can do a half match transplant. So the family has to decide because the risk changes. So I give the choice and explain the risk to each family. In a good center with a lot of experience, even haplotransplant in a young child is quite acceptable nowadays. We do a lot of those transplants if the family wants. Fully matched brother or sister is a standard of care, so everybody should be offered. If the family is willing, then we can do the other type of transplant as well, matched unrelated transplant and haploidentical transplant or half matched transplants.
All right. So, as you mentioned, even the siblings, the brother, sister, can be the donors. Usually, parents will have this concern that will something happen to the donor.
Correct.
So, what do you tell about that?
Yeah, so this is a very common question because if family has got two children and then one is thalassemia, other is normal, they don't want to touch that normal child.
Right.
Right? Because if something happens to that child, then it becomes a major problem. So,
right.
So that is their concern. But one good news is bone marrow donation involves very, very little risk to the donor.
Mm-hmm.
Say, for example, if I am donating a kidney to somebody, I have two kidneys and one is taken out. Now I have one kidney. Mm-hmm. Okay, for the rest of my life. Okay. Right? Whereas bone marrow donation is more like a blood donation. Mm-hmm. You take some bone marrow, your body will make more bone marrow. You don't lose anything. So other than that small procedure which they need to undergo, and which is a very safe procedure, so I can practically assure the parents and families that nothing will happen to the donor. Okay. The risks are very, very minuscule. Okay, so they can confidently the donors we can collect the stem cells with the donor without harming the donor at all.
All right. So, could you also tell us, is there any long-term risk in this bone marrow transplant?
Usually not, but there are some things which we have to be aware. So one of the important things which may be important for families is that because we are using medicines to remove the bone marrow, those medicines are more or less the same medicines which we may use for cancer treatment. So there can be some leftover effect of these medicines. So one of the important thing is, even if the child is completely cured of the thalassemia, the chance of them having a children later on will get compromised. Or in other words, there is a slight increased risk of infertility when we go through these kind of transplants, this kind of treatment. But at the same time, we have to understand that even in a normal thalassemia patient who are on regular medication, if the iron overload is not taken care of, they also will not be able to have children because of the iron overload affecting the hormones and things like that. So majority of the patients in our country, they don't have, many of them will not have children even without transplant because of this iron overload problem.
All right. So thank you, Dr. Stalin. I believe this would have helped all those parents to just slow down and not really get involved in that overwhelming feeling and just make the right decision.
Yeah, and one more thing I want to say is that see, thalassemia is not an emergency. So even if they want to thinking about transplant, you don't have to make the decision in 1 day or 2 days or a week.
Right.
It is always you can gather enough information, you can discuss with your doctor in detail, and even within a few months, if you take a decision, that is also sufficient. It is unlike in other situations where, say for example, in a leukemia we are doing a transplant, that will become an emergency transplant. They have to make the decision then and there. Whereas here it is not like that. You have got enough time to think over and then sort of gather all the information, consult the wider family, then make a more informed decision.
Right. So yes, thank you, doctor. And
thank you.
If you are someone who is at a stage of making a decision, probably you should slow down, think about it, consult the right support, and make a decision. So, you're listening to Little Warriors. I hope this was informative. So, I am Annie Shreya signing off, host of the day, and see you next time.